this opportunity to introduce myself and our department here at Indraprastha Apollo Hospital, and most importantly, my field of work to my respected senior and fellow pediatricians here. So we at the Apollo Center for Genomic Medicine, we aim to give all the comprehensive diagnostic services, genetic services, as well as multidisciplinary care for patients and families with the genetic conditions. And heading our department is Professor Dr. Kumar, who is the Senior Consultant Advisor, Virtual Consultant at the Apollo Center for Genomic Medicine. And he's otherwise the Chief Consultant Genetics at the University of Wales, Cardiff. And then we have myself, and then we have a board certified genetic counselor. So today, as part of my talk, I would like to give a case-based overview of the scope of genetic evaluation and genetic testing in the pediatric practice. I'm very fond of this slide because I sincerely believe that clinical medicine is like investigational medicine. In the 21st century, although it has dramatically changed since Sir William Osler established the modern residency program in Johns Hopkins in 1889. In the early 1900s, the techniques of clinical examinations were at their peak. Clinical tools and basic investigation tools, they were the mainstay of the clinical evaluation to look for various clues and to reach at the definitive to diagnose diseases. Clinician, with its armamentarium of good clinical skills, basic radiological and laboratory investigations, they were diagnosing common conditions confidently. And then as the techniques of investigation became more and more accessible, sophisticated, with complex diseases coming up, and rare diseases becoming more and more common, along with, of course, the frequent litigations. It has made the clinician wary of, it leaves little scope of error. So it is but natural that the physicians rely on modern investigations, and particularly now in this era of genomics and high throughput laboratory medicine, the physicians and specialists, they are bound to make use of these technologies. But we still believe that a correct and complete phenotyping is extremely important, which may need evaluation of the patient by various multiple specialists, collaboration between them to reach to the clinical differentials, order the specific tests in order to reach a definitive diagnosis. This is what is optimum use of the specialist skills. And this is what I mean when I say that clinical medicine is like investigational medicine. More and more diseases are now becoming, they are found to be having a genetic component. Our DNA is proving to be a powerful tool. Genomic tests have become an important component of medical practice. And genetics can truly claim to be the central basic science of medicine in this century. Now in India, with the high incidence of the birth, with the high incidence of consanguinity, endogamous populations, the rare disorders are not that rare in India. And the estimation of the prevalence of rare disorders, though it becomes a problem in a country like ours, where there is a lack of a centralized clinical registry for patients. Leave aside the registry, there is lack of newborn screening programs, which has again led to a distending proportion of the Indian population ailing with the genetic diseases. So we feel that the genetic disorders are essentially, they are much, much less underdiagnosed than less prevalent. So coming on to the basics, we know that genetic material in the cell is arranged in the form of chromosomes, 23 chromosomes getting inherited from each parent, forming the 23 pairs of chromosomes inside the nucleus, which each of which have about 1,000 genes, which then code for the proteins. And genetic disorders, they are simply classified into three main categories: the chromosomal disorders, the single gene disorders, and the multifactorial disorders. Although in between these three categories, there is an entire spectrum of the genetic disorders. So chromosomal disorders are the ones that happen because of an abnormality in the number or gross structure of the chromosomes, classic example being Down syndrome, and the classic test for this being a karyotype, a chromosomal analysis by karyotype. However, in between the chromosomal and the single gene disorders, there is microdeletion and duplication syndromes, which are mainly the syndromes which occur because of loss or gain of the chromosomal material, which is 2 to 5 megabases. So the size of the chromosomal segment which is lost or which is gained, which leads to actually the disease, is smaller than that can be seen in a regular karyotype. So these microdeletion and duplication syndromes, like the Cry-Ducat syndrome, the 4p minus or the 5p minus syndromes, they can be diagnosed by different tests now. But the basic test to diagnose these used to be FISH, which is the fluorescent in situ hybridization, in which there are fluorescent probes which are targeted to that particular segment of the chromosome which is suspected to be deleted or duplicated. So we have to have a clinical suspicion to be able to order a specific FISH test to be able to diagnose the microdeletion or duplication syndromes. Single gene disorders, the classic example being thalassemia, are disorders which occur due to mutations in a single gene. They disrupt the sequence of the DNA in a single gene, leading to the disruption of the formation of that particular protein. In case of thalassemia, the beta globin chain or the alpha globin chain, depending upon which gene is involved. Polygenic or the multifactorial disorders are the ones which occur because of a defect which have a genetic component, but which also have an environmental component. And it is a collaboration, or it is in concordance of the genetic as well as the environment that these diseases occur. And a lot of malformations are considered to be multifactorial. In between the single gene disorders and the multifactorial disorders, there are the oligogenic disorders, or there could be modifier genes, which occur because of the interaction of multiple genes. So they do not occur because of the disruption or a mutation of a single gene, but a number of genes need to be sort of disrupted to be able to have the phenotype or have the clinical signs and symptoms of that disorder. A few oligogenic disorder, there is oligogenic inheritance being described in deafness now, being described in retinitis pigmentosa now. And Hertzsprung disease is a typical example of a multifactorial disorders. Now I'm coming on to my first case to further elaborate the first genetic technology or the genetic testing that I would like to highlight here. And here I'm providing only the case summary so that we can, I'm not going into the details of every case, so that we can cover up more cases, and I will be able to give the audience an overview of the genetic disorders and the genetic testing. So this was a 4-month-old girl child with complaints of not growing well. This was a term baby. The birth weight was 2.1 kgs, and there was global developmental delay. At 4 months, there was no social smile, no visual fixation, and there was no neck holding. And on examination, the weight was, so there was severe failure to thrive along with the microcephaly. And there was dysmorphism, as we can see here. There was ptosis, low set ears, broad nose, retrognathia, and high arched palate. The systemic examination, or there was no organomegaly, the tone and DTRs seemed to be fine. So this was essentially a term SGA baby with failure to thrive, developmental delay, and dysmorphism as described. Grossly, I would give this as the clinical summary. And the clinical differentials for such a case, congenital infections, teratogenesis, or it could be genetic, which includes chromosomal syndromes or single gene syndromes. So in chromosomal syndromes, again, it could be either aneuploidy or deletion duplication syndromes, or it could be single gene syndromes, like a lot of my dysmorphic syndromes could behave in this manner. There could be some primordial short stature genes which might be mutated. Prader-Willi could present in this manner. There could be congenital myopathies, dystrophies in which there would be failure to thrive and retrognathia, and there is a partial overlap there, and rarely metabolic disorders, although we wouldn't see the intrauterine manifestations rarely, in metabolic disorders. So we would investigate the child according to the clinical differentials, and serum CPK was normal, ammonia lactate, echocardiography. There were no other malformations that were essentially found. Now, coming on to the basic thing, the history, back again to the history. Now, as we came back, as a routine, we take a family history. And in the family history, now this girl child, the first cousin of this girl child. So this is the proband here. She is a girl, and this is the father of this girl. And the brother of this father, he has an 8-year-old boy child who has intellectual disability, spasticity, being diagnosed as having cerebral palsy. And then this couple had a pregnancy which got diagnosed with CNS malformation, and they terminated the pregnancy. So we knew here now that there is probably the genetic, there is a genetic component. Suspicion increases now with this family history coming in. Now we always take a 3-generation family history. And of course, in this case, it was all the more important as it was, we were getting some positive family history. And as we went up in the generation, we found that the grandfather of this proband here, the grandfather's brother, he also, in his grandchildren, there was a female child who had died at 3 days due to congenital heart disease. There was this couple had another pregnancy which had holoprosencephaly. And they had a living child, a female child, who had intellectual disability, congenital heart disease, and camptodactyly. So now we're looking at, and the rest of the family history on the maternal side and everything was fine. So now here we have a 4-month-old with a family history on the paternal side with malformations, intellectual disability. And here the component now, the genetic suspicion becomes higher and higher. And now we know that probably we're looking at some malformation syndrome. It could be chromosomal, it could be single gene. So we did a karyotype in this girl, and the karyotype came out to be normal. However, because of a very high suspicion of a genetic disorder, we went ahead and we did a chromosomal microarray, which actually revealed a chromosome, a 9.2 megabase deletion on chromosome 7. So there was an area of chromosome 7 which was deleted, and there was a 13 MB gain on chromosome 11, which means that there was an extra material of chromosome 11 which got detected. So we didn't know. So here I've put in the pictures of chromosome 7 and 11. However, in the microarray report, where we sort of zoom in and go inside the chromosomes, and there are multiple probes for each of the regions of all the 46 chromosomes, the report just reveals whether any region of a particular chromosome is deleted or is gained. So the report came back as chromosome 7 has a 9.2 MB deletion and chromosome 11 has a 13 megabases duplication. And to give you an idea of the region of, so 13 megabase gain means that there were actually about 500 to 700 genes in this area, which were duplicated, and there were about 300 to 500 genes of chromosome 7 which were deleted. So they were huge areas. Now the 5-year-old living girl, the paternal cousin, we also got the microarray. This was a good educated family, and they immediately they thought that they should evaluate the other children as well. And to our surprise, when the other 5-year-old, when we tested her for a microarray, we got a chromosome 7 duplication and a chromosome 11 deletion, which means that, you know, the part that was deleted in our proband 4-month-old was duplicated in this child, and the same region was deleted as was duplicated in our proband. So how do we explain this now? So now chromosomal abnormalities, there could be numerical abnormalities or there could be structural abnormalities. Numerical abnormalities are when there is an increase in the number or a decrease in the number of a particular chromosome, which is known as aneuploidy, or there could be polyploidy, which are generally severe disorders, and very few of them survive, like, for example, monosomy X and trisomy 21. Now, structural abnormalities are also, you know, deletions, duplications, inversions, ring chromosomes, etc. Now, what was happening in this particular, in these children was that there was translocation, there were deletions and duplications. So we suspected that there were translocations happening, but they were not balanced translocations. Just before I explain the results, I would like to just say, show diagrammatically or in a picture that how does a microarray report or data when it is done, how does it look like? Now, karyotype is like, for example, chromosome 10, 11, they look like, you know, we just see the structure of, we just see the number of chromosomes, and very grossly we are able to see the light and dark bands, and we are able to make able to comment on deletions, gains and losses of very big chunks of chromosome in the karyotype. So only about 5 to 10, at least 5 to 10 megabases need to be lost. So at least, you know, 500 to 1,000 genes need to be lost or gained to be able to see on a karyotype. However, microarray can detect, it gives us a much zoomed in picture of each chromosome, describing in detail. So the red dots here indicate deletions, and the blue dots here would indicate duplication. And there are various probes which are specific for each of the regions, each of the minute areas of the chromosome. And the resolution of microarray is about 50 kilobases. So in a karyotype, we are talking about megabases, while in a microarray, we're talking about kilobases and 50 kilobases. So which could be 1 or 2 genes also. So, you know, it could pick up rarely a deletion of a single gene as well. So it's a much higher resolution technology. And now whenever we are suspecting a chromosomal disorder, except when we are suspecting a clear-cut aneuploidy or a trisomy 21 or a Turner syndrome, for any other chromosomal abnormality, we would almost always do a microarray and not a karyotype. So this is again just to compare between a karyotype and a microarray. It's a satellite picture, like, you know, if karyotype shows you the country, microarray would probably show you each and every building in each and every town, in each and every village of every country. So now coming back to our case, now here we saw that there was a deletion and duplication happening, and there were 2 chromosomes that were involved, which were the chromosome 7 and chromosome 11. Whenever we get a deletion and duplication in the same child, what we suspect is a translocation. When any of the parent is a carrier of a balanced translocation, for example, if here in this case, one of the parent is a carrier of a balanced translocation, which means a portion of chromosome 7 got deleted and it got attached to chromosome 11, while a portion of chromosome 11 got cut and it got attached to chromosome 7. That means no net chromosomal region was deleted or duplicated. They were just translocated, and hence the parent is a balanced translocation carrier, and hence they would not have any signs or symptoms since no genetic material is lost or gained. However, when they form gametes, such a parent forms gametes, the gametes may be normal balanced or the gametes may be unbalanced. And in the unbalanced gamete, there could be either of the combination, that is deletion of one particular chromosome or duplication of the other chromosome. So that is what was happening in our family here, where these fathers of all these children, the fathers and the grandfathers, were probably inheriting a balanced translocation. And somehow in this generation, it was all manifesting in the forms of unbalanced chromosomal translocation. So the gametes that were formed by these carriers of balanced translocation were probably unbalanced. Now this child unfortunately died at 11 months of age, and we got this couple again for a prenatal diagnosis. And unfortunately, this pregnancy also had a similar kind of unbalanced chromosomal constitution, and the couple decided to discontinue the pregnancy. So obviously, we can't treat chromosomal translocations, but in this case, it was prevented during the next pregnancy, and the parents were told that the chances of recurrence are up to 30 to 40%, and hence the reproductive options could include either natural pregnancy and prenatal testing, as was done in this pregnancy, or in the next pregnancy, they could just, they could opt for an IVF and a pre-implantation genetic testing, or a sperm donor. So just an overview of what are the, in the clinic, sitting in the OPD, chromosomal disorders and single gene disorders. We can't really all the time differentiate whether a particular malformation syndrome or a particular child with dysmorphism could be due to a chromosomal abnormality or a single gene abnormality, and hence there is a lot of overlap. But there are some things that that we do keep in mind before sort of ordering a test for either the chromosomes or testing for the single gene. For example, like usually chromosomal disorders are sporadic, and usually we wouldn't get a family history. It was not the case here in this particular case scenario, but in general, it is the single gene disorders, particularly the recessive ones, in which we do see a recurrence more often. And the phenotype, we usually, if a disorder is congenital, if there is multisystemic involvement, if there are malformations, dysmorphism, goes more in favor of chromosomal. However, single gene disorders, age of onset could be variable. They could have the onset of symptom from any time after birth to adulthood, and manifestations are very variable, but usually they wouldn't be multisystemic. But again, having said that, there is a lot of overlap, as you would see in the next case that I'm just going to be presenting. So this was a 4.5-year-old boy who presented with global developmental delay. There was no neuroregression. The child was improving slowly, and there was speech and cognitive delay, which was much, much more than the motor delay. And then the child had a lot of malformations that were noted at birth. He had tetralogy of Fallot that was operated, then cleft palate, bilateral congenital cochlear dysplasia, and moderate hearing loss, along with optic disc coloboma. Now, the finding of optic disc coloboma becomes important in this case, as it is a specific finding, and it was good that that a thorough eye examination was done for this child, and such specific findings can give us a clue to the diagnosis. The growth seemed to be normal. There was no characteristic dysmorphism. He was a second-born child. No other family history, non-consanguineous parents. Now, in a case of multiple malformation or multiple developmental abnormalities without any family history, I would like to keep chromosomal syndromes as my first differential. However, in some cases, we do suspect single gene malformation syndromes, or it could be simply multifactorial or an acquired malformation syndrome. For example, there could be, the deformation sequence, the disruption syndromes, or developmental abnormalities because of congenital infections or teratogenesis. So these are all, where the genetic component is much less. So for us, the chromosomal and the single gene are the ones where there is a strong genetic component. And then, of course, whatever we suspect, the genetic test varies depending upon the clinical differential. Now, for this case, with this constellation of symptoms and signs, the first differential is CHARGE syndrome. It is a single gene syndrome, and it's caused by mutations in this one particular gene, which is inherited in an autosomal dominant fashion. And after ordering the test for it, we got a heterozygous mutation in this one particular gene, leading to a definitive diagnosis. And of course, again, as for most of the genetic syndromes, it's not a definitely treatable condition, but the family was able to get a definitive diagnosis, as well as, we do give a lot of recommendations for the surveillance. The family's main concern was for the cochlear transplant, and they wanted a cochlear transplant for the child in spite of the cognitive delay in the child. And but it has been, so the family was counseled that cochlear implant in such children, it has its own risks because of the airway problems and anesthesia problems. Moreover, because of the cochlear dysplasia, it is very, it's only a 50% success. So 50% of the children with CHARGE syndrome, they would have auditory nerve abnormalities. And when you have the auditory nerve abnormalities, even the possibility of a successful hearing with a cochlear implant decreases. So that's all, that's what we discussed with our pediatric ENT specialist, and then together with the family to be able to decide the further course of action for the implant. Now, coming to the single gene syndrome, now genes are structures which are inside the chromosomes, and they have exons, introns, promoters, and they actually transcribe and translate into the various proteins. And single gene abnormalities occur usually due to point mutations, which means that, when there is a sequence of nucleotides which is forming the gene, there is a change at a particular position of the sequence of the gene, which sort of disrupts the reading frame and hence disrupts the protein function. So the test for single gene disorders is to sequence the gene, to sequence the DNA, to be able to pick up that change in the sequence or change in the reading frame. And so traditionally, sequencing started from the first generation sequencing started, and then, we came to the capillary sequencer, wherein the material, the DNA is put inside an equipment which then can sequence 96 bases at one time. And now this technology has become more and more automated and more sophisticated, and now it's called next generation sequencing. The purpose is the same, to sort of sequence the genes. So now next generation sequencing, which includes exome sequencing and panel testing, these next generation sequencing, they actually sequence the entire 28,000 genes on all the 46 chromosomes, on all the 23 pairs of chromosomes. So they are very, very high throughput technologies, massively parallel, which means their ability to perform millions of sequencing reactions simultaneously. And it's done on a very miniaturized platform. When every nucleotide in the genome can be sequenced, that's called a whole genome sequencing, and it is still it is now available in the clinics, but we still order it very, very rarely. It includes the genes as well as the coding areas of the gene, as well as the non-coding areas of the gene. So the coding areas of all the genes are called the exomes. So when you are sequencing every exon of all the genes, then it's called an exome sequencing, because maximum mutations or sequence disruptions would occur in the coding areas of the gene, which are the exons. So the whole exome sequencing, what I'm sure all the doctors here would know that whole exome sequencing is basically when we are sequencing all the coding regions of all the genes. And 99% of the mutations or disruptions of the genes occur in the exons. At least that's what we know, because we haven't done whole genome sequencing till now in a lot of patients. And when you're not sequencing all the genes, all the 28,000 genes, when you want to sequence only multiple genes of interest, say the child has cardiomyopathy, so you want to sequence only the cardiomyopathy genes or epilepsy genes together, then it's known as a panel testing. So again, I'm not going to be going into the detail of this, but it's just to highlight that the next generation sequencing, which includes all of this, is a sophisticated test, and it's not a very simple test that you put in the DNA and the sequence comes, and then you're able to just pinpoint the mutation in one go, because they are extremely high. The data which is generated is extremely large, and it needs a lot of sophisticated databases to sort of analyze that data to pick up the mutation or the change in the gene of our interest. So this is again a busy slide, but it's just to show you that when when a person's whole exome sequencing is done, then in a whole exome sequencing, approximately 10,000 variations are detected. And among those 10,000 variations in all the genes, those are the type of variations. Most of those variations are of the type which make each other different. They are not the type of variations which cause disease. So out of all these 10,000 variations, we have to, the softwares, with the help of in silico analysis, the bioinformaticians, along with collaboration with the clinical geneticist or the specialist who has sent in the test, they have to do clinical correlations, and they have to then pinpoint the variation or the mutation which is probably causative in this in our patient. And then there are specific guidelines for classifying these variations as pathogenic or benign. So if a particular variation identified at a particular point in the gene has never been reported before for any disease, and it has been strongly reported in population databases, then it is more likely to be benign. On the other hand, if that particular variation has been reported before in a disease, in the disease which matches the disease phenotype in our patient, it is more likely to be pathogenic. And then there are various databases which sort of analyze that how far the gene is disrupted by that particular variation. And on the basis of that, the pathogenicity is sort of given to that particular variant. And hence, in a report, when you look at the whole exome report or a whole genome report, the variations are reported and they are classified. A classification for them is given as pathogenic or likely pathogenic or benign. Now, this brings me to another case which highlights the importance of these variations and the importance of how to correlate them. So this is again a 9-year-old girl, and it's a common scenario that we would see in a pediatric OPD with mild intellectual disability, learning problems, poor scholastic performance, studies in grade 4, which is okay for a 9-year-old, but calculation, memory poor. There has been mild global developmental delay. There are some behavioral issues. When we examined, there was mild hyperlaxity, nothing much. Bilateral mild hearing impairment was noted. And this was a term-born child, 2 kilograms at birth. There had been no neonatal complications. And she had mild, the height was between -2 to -3 standard deviations. And now we noted the dysmorphism the moment we looked at the face. Now there is a flat root of nose, very, very long palpebral fissures. As you can see in the lateral picture, there are very high arched eyebrows, and there is a lateral interruption of this eyebrows. I'm not sure how far you can see, but there is a discontinuation between the medial part of the eyebrow and the lateral part of the eyebrow, which is again very characteristic of this particular genetic syndrome that we diagnosed in her. And it's a very common genetic syndrome. I mean, commoner of the rare disorders. There was some joint laxity, and then there were some fetal finger pads here. Bone age was absolutely appropriate. And here, this was Kabuki syndrome. We suspected a Kabuki syndrome. Now, Kabuki syndrome was actually first reported in medical literature by a Japanese physician, and the disorder was originally called Kabuki because of Kabuki makeup, actually, because of the facial features of the many affected children. They resembled the makeup which were used by the actors in Kabuki, which was a Japanese theater form. So the name came from there, but you can see the resemblance of our patient with these other patients who have been described in the literature. So we suspected this condition strongly, and there was a variation. We sent a whole exome analysis. So this was a variation which was detected in the gene KMT2D, which causes Kabuki syndrome. It was in the exon 50 of this particular gene. And this was the variation. That means that in the coding region, at the 15883 position, there was supposed to be G, but it was replaced by a T, which caused this particular change in the protein coded by this particular gene. This change was heterozygous, which means that, for every gene, as we know, there are two alleles. Since there are two chromosomes, we all have two alleles of each of the genes. A heterozygous change means that the change was present in one of the allele of the KMT2 gene, which caused the disease Kabuki syndrome. However, the classification that was given was uncertain significance, which means, and the reason why it was given was uncertain significance, was that this was a novel variation. It had never been reported in any patients with the Kabuki syndrome. It had a low allele frequency in the population databases, which means that this particular variation is not reported commonly in the normal general population. That means it's a rare change that has happened in the gene. And the in silico analysis, that is, when there are some softwares by which a bioinformatic analysis about how this particular change in the protein, that is glycine is getting replaced by the amino acid tryptophan, how this change can sort of disrupt the protein structure or the protein folding, or whether it is present in the active domain of the protein. So all this in silico analysis showed that this change was damaging to the protein. And then parental targeted test was sort of, it becomes important in this case. We need to examine the parents for this particular variant, as if either of the parent has the same change, it is less likely that this change has resulted in the clinical signs and symptoms in the child, while the parent is asymptomatic. Hence, the parental targeted testing becomes important. And so the lab had recommended that parental test is recommended, and classification of the variant may change based on segregation analysis, which means that, if we do the segregation, segregation means that if we do the parental test and we know that this variation is not present in either the mother or the father, it has arisen de novo by chance in the baby, it is more likely to be damaging, and then they would like to change the classification to pathogenic. So that's how we sort of analyze the variants of uncertain significance. The most important thing is to go back to the lab and tell them that, this is the condition that we are suspecting clinically, how far is it correlating, and sometimes the parental testing becomes important, as in this case, to sort of reach to a definitive mutation or the definitive gene diagnosis. And now what do we gain by the gene diagnosis? Again, the parents were, it stops them from undergoing any surgeries for short stature. Here, we did an echo because approximately 70% of individuals, they do have aortic stenosis, hypertrophic cardiomyopathy during their course of life. ENT evaluation for cochlear implant. She did have hearing impairment, and these children have shown good response to growth hormone therapy. So in case the short stature remains, and so they do show a growth hormone, good response to growth hormone. So that's how we counsel them and help the family. Again, a very common condition, again, commoner of the rare disorders, but a common problem that we see in the OPD, in a pediatric OPD, short stature. So 10-month-old female child here, I have just shown here, so this to just highlight the degree of shortness. This was a 10-month-old girl child and with normal developmental milestones, and she was severely intrauterine growth restriction was there, and birth weight was 1.1 kg. There was proportionate short stature, and then you can see here that the weight, length, and head circumference are way below the average for the age. And then apart from the basic, some mild dysmorphism, she was essentially, fine and a playful girl, and bone age was much delayed. There were no capitate or hamate, and it was much delayed. And in such a case, we do suspect a primordial short stature, and this was what we suspected. We suspected her to be affected with this particular primordial dwarfism syndrome, which is called a microcephalic osteodysplastic primordial dwarfism, MOPD type 2. And she was found to have the mutations. And here, as you can see that, the classification has been given as pathogenic, which means that these two variations that were detected in the gene were definitely causing the phenotype. This was our main clinical differential, and the lab could pinpoint the mutations. Now, this particular short stature syndrome is an autosomal recessive genetic condition with marked microcephaly. There is an increased risk for cerebrovascular disease and insulin resistance. These children need to be on follow-up. It ended the ordeal of the parents running from post to pillar with failure to thrive, with vitamin supplementations being given, with variety of foods being tried, sort of ended all that tussle for them, gave them a diagnosis. Of course, it is a chronic, and it is a diagnosis that's going to stay with them forever. We did tell them that the risk of recurrence for such a condition is 25%, and hence whenever they conceive next time, it will be good to get a genetic testing done during the pregnancy. So genetic disorders are essentially now being diagnosed as genetic testing is being done for practically every genetic disease in every system of the body, genetic disorders of the skin, then the connective tissue disorders, of course, the pediatric tumors here in optic gliomas like neurofibromatosis, in the neuromuscular conditions where we are suspecting, muscular dystrophies, congenital myopathies, and in immunodeficiencies as well. So this is sort of my last case wherein, and this was actually, it's an old case of mine where the proband and affected SIB were not available for us, and it was actually a struggle to pinpoint the diagnosis. But I wanted to highlight that the power of genetic testing sometimes in these families where there is no proband or the no affected child is also not available. So here, the moment this couple came to us and they said that there was a disease, two females having died of a similar disorder, and the parents were consanguineous, which means that they were married within the family. So we know that this is an autosomal recessive disorder. So this double line here means that this is to depict consanguinity, and this is the father and this is the mother. And so the moment we have this family tree there, we know that this is an autosomal recessive genetic disorder, most likely, because we are talking about consanguinity, which increases the incidence of autosomal recessive disorders by 2 to 3 times. And we are talking about 2 children who have had similar illness, and they have died. So this was an autosomal recessive genetic disorder. Now, what did these children have? The available information was very, they were just sketchy medical records. So the first female child died at 11 months of age, and the second one died at 7 months of age. The first child, there was not much testing done. There was a non-healing preauricular abscess which developed at 8 months of age, and she was growing absolutely fine till 8 months. And then she developed sepsis and multi-organ failure. And just one record of head circumference we got at 8 months of age, which was 38.5 centimeters. And we thought that was that stood out because the head size was at -4 to -5 standard deviations at 8 months of age. But according to the parents, the child had had normal developmental milestones. Now, the second child had had some bit of investigations. She developed pneumonia at 2.5 months of age, and then she had persistent cough fever, and then she had seizures, and then followed by she succumbed to the illness at 7 months. And at 6 months, here we had a TLC, which was 2250, and the neutrophil count of 20. And there was a myeloid cell maturation arrest, which was highlighted in the bone marrow. So we knew that it was probably some kind of an immunodeficiency. And here, because of the neutropenia, we thought it could be, there could be something known as a congenital neutropenia. Severe congenital neutropenia, and for which, very 2 small, very genes are implicated for that particular condition, which can be actually sequenced by a very basic Sanger technology. We don't need to do a next generation sequencing. So we quickly did a couple carrier analysis, which means we tested the parents for any variations or any mutations in this HAX1 and ELANE gene, but they were found to be normal. Now, we didn't have any immunodeficiency gene panel available in the center. So we just ordered the exome sequencing of the wife to be able to, sort of sequence all the immunodeficiency genes. And this was obviously like, search of a needle in a haystack. We didn't even know what kind of immunodeficiency are we looking at. And then there was that head size microcephaly in the first child. We didn't know whether it was acquired, whether it was congenital, whether it was related to the illness or not. And the whole exome sequencing actually revealed a heterozygous nonsense variant, which means that one copy. So this particular gene, NHEJ1 gene, is a gene implicated for severe combined immunodeficiency. And in the wife, we found a variation in one copy of this particular gene, which was causing a stop codon, which means there was a truncation of the protein at this level. So, we knew that, so there was, we found the mutation. And then, we just sort of took off from there, and we found the same variation in the husband, and we were able to provide the family with the diagnosis in this particular NHEJ1 related severe combined immunodeficiency. There is microcephaly, which is reported. And so the family, we were able to provide prenatal testing, at least offer prenatal testing. The couple didn't come back to us for any prenatal testing, though. Again, just to highlight now, these are my last few slides. I think I'll just take 2 more minutes. So not now here till now, we haven't had any definitive genetic treatments discussed at all, but not all genetic disorders are untreatable. And this is a very short case, 2 brothers, 14 and 16 years of age, acute, excruciating, unbearable episodes of pain in hands and feet, and they were being treated for rheumatoid arthritis and immunology. They had been shrugged off to psychiatry, and then they were referred to medical genetics, and they were seen to have these angiokeratomas. These are small, reddish papular lesions, very small pinpoint lesions. On the trunk, which is actually characteristic of Fabry disease. It's a lysosomal storage disorder, and because of deficiency of this particular lysosomal enzyme, the substrate sort of accumulates and causes vascular occlusion in the skin, in the vessels, and that's what causes the pain in the joints, the neurogenic pain actually, and they are more prone to renal problems, they are more prone to strokes. The diagnosis was confirmed by enzyme analysis. Now, fortunately, there is an enzyme replacement therapy available for Fabry disease, which was started for these 2 boys, and they are doing extremely well. List of treatable genetic disorders is growing. We have special diets, indigenous ones for inborn errors of metabolism. The Indian Society of IAM is now moving towards the newborn screening. And I will have to skip this case. This is a metabolic, this is a case showcasing the inborn error of metabolism and how the treatment of particular inborn error of metabolism, methylmalonic acidemia, the short-term and long-term treatments, when they are started on time during the newborn period or during early infancy, gives extremely good outcome. And then there are now treatments based on molecular pathogenesis also of diseases. We have, of course, Spinraza for SMA, and some drugs for DMD for certain types of mutations. And I would like to end here. I think my time finishes for the presentation, and I'll be happy to take any questions. Thank you.
Thank you, Dr. Divya. Just on time. Absolutely, in a nutshell, you've given a very comprehensive, elusive information. I'm sure this is going to be very useful to our fellow pediatric colleagues. I think there are a few questions here, Divya. So the first one is from Dr. Arun Wadhwa, as always. Is there any benefit of doing DNA analysis by someone like 23 and me in normal people like us? Right. Is there any benefit of doing DNA analysis by someone like 23 and me in normal people like us? Sorry, I couldn't get the question. Can you see in the chat box? What does it mean?
Sir, I can see. So I think what I get is that sir is asking that is there any benefit of doing the DNA analysis in normal people? Can we diagnose any pre-symptomatic conditions, genetic disorders?
Right. By doing chromosomes only, right?
By doing whole genome sequencing, I believe, there are now labs which are advertising to do whole sequencing and whole genome sequencing, and they sort of claim to diagnose heart diseases, your risk to developing coronary artery disease, or your risk to develop hypercholesterolemias by doing a whole genome sequencing. But as of now, this is not the recommended thing, and it's not in the diagnostic phase, because these are at most these variations are all multifactorial disorders, and by testing we'll be able to tell you that the lab will be able to tell you that you have these variations in these genes, but these are all modifiable by the lifestyle changes. So
I know. There was a big advertisement a few years back in the market. I think maybe 4 or 5 years back. But I mean, as we all know, that I mean, if we do the whole genome sequencing, there will be 10,000 aberrations in all of us, every one of us who is normal. So how on earth one is going to decide that you are at risk of this or that? I think this is taking a bit too far. I agree. I don't think this is useful. The next question you can see.
Dr. Sandhya has asked approximate cost of analysis.
Okay. So I think genetic tests are now becoming more and more. I think they're just dropping down. If we are talking about a chromosomal microarray, it is anywhere between 10 to 15,000 by most of the laboratories. The best of the best microarray, the high resolution microarray, and whole exome sequencing is also somewhere between 15 to 20,000. And so yeah, that's
around 18 to 20,000. Most of the labs are doing.
Dr. Sandhya, Dr. Sangeeta.
Dr. Divya, brilliant presentation. Recently, what happened was one of my cousins in US, they got their prenatal genetic testing done, both for the husband and wife, and they found they were both carriers of Sanfilippo's syndrome, right? So then they went for amniocentesis and all that, and they found that the child also had it. So can you tell me your experience with that? And basically they were then asked to terminate the baby, and it was a little this thing. But what is your experience in the in prenatal testing and stuff like that? How is it foolproof? Is it accurate fully? Like, I mean, there's always is there any error, question of error or anything?
So, ma'am, the thing is that prenatal testing now, it has becoming more and more standardized, and it is actually a very, very commonly performed test now. And if you ask me the laboratory or the technical error, that is not much, I would say, like for any other test. For the laboratories that are doing the prenatal testing, they have more stringent quality control criterias. I mean, whatever accreditation is needed for a prenatal testing, it is much more stringent than a postnatal genetic testing. However, in a prenatal testing, whenever we are doing a prenatal testing on an asymptomatic fetus, so we do prenatal testing for two reasons. One is when we are seeing in the ultrasound there is some abnormality. That for that, when we do a genetic testing, we have some clinical features to correlate with. However, when here we are dealing with a normal healthy fetus, supposedly normal healthy fetus, normal on the ultrasound, but we have done the test only to diagnose the genetic. We need to be very sure that these mutations are actually damaging. If these mutations that have been characterized in the couple are we are sure that these are pathogenic variations, then they do warrant a prenatal testing. And then if detected, then in the fetus, if it is in the homozygous state, and if that is predicted to be causing disease, then most likely it will cause the disease. So
they were asked, they have a normal baby first, and this was their second baby. So, I mean, very rare disorder.
Very rare disorder, but preconception carrier testing is becoming more and more prevalent, especially in the consanguineous couples. So even if you see that, even if someone is a carrier, if the couple is a carrier of a mutation of an autosomal recessive gene, then there is only a 25% chance that the baby will be fine. So there is a 75% chance that their children will be fine. And you're saying that already they have a previously normal child.
Yeah.
So, it is unfortunate.
What's the test being done in all these women who are pregnant from the blood to find out any congenital disorder in the baby?
Ma'am,
They do it routinely, I think, in the US, and here only if it is asked for at some 20,000 rupees or something like that.
Yes, Yes, here. So again, we are doing an exome sequencing, but we are trying to look at only the recessive disorders, and it's being done in the couple. Again, to, sort of see whether both the couples are carriers for the same gene mutations. Only then it will sort of, there is a chance of causing the disease in the baby. But we are not offering it to all the couples as of now. We are, couples who are extremely, like, there are, so we do, our policy is like, there are certain conditions which are commoner in certain communities. So there is an Agarwal community, there are certain mutations. So if a couple does come to us for a preconception counseling and they ask us that, is there anything else that we can do for preventing genetic disorder in our children, we do offer them those targeted testing. That means that, we don't offer them straight away to test for all the gene mutations, but to test for conditions which are commoner. Hemoglobinopathy is one, DMD, SMA, the commoner conditions, as well as for if it's an Agarwal community, then we do ask them to do the common gene mutations which are prevalent in that particular community. So that's what we are following. But of course, I mean, if it's a consanguineous couple and they are they ask for testing for to rule out sort of any genetic disorders, we do offer them a whole exome for the couple.
Don't they do it at least in US, they do some testing from the mother's blood to find out if the fetus is normal or not?
Ma'am, that is, I think they would be talking about
No, not routinely, not routinely.
they
Not everybody.
They would be just screening for Down syndrome, ma'am. That is
Okay.
That's okay. But
That's
not,
okay. That we all do. Okay.
but
fine.
not the in a healthy.
no, ma'am.
Right. There is a couple of questions from Dr. Anju Singh. Is whole exome sequencing better than clinical exome sequencing to avoid double expenses? And the next question, how would also can you please guide us regarding the veracity of various private labs doing these tests?
The second one is a little difficult. But, for the first one, the whole exome sequencing and clinical exome, it's so there are certain clues actually. So like, where clinical exome is a panel of genes which are they are the genes which are the commonly diagnosed genetic disorders. So these are 5,000 to 8,000 gene panel. So while I said that whole exome sequence, actually that test includes analysis of all the 28,000 genes which are present in our body. Clinical exome includes analysis of only the disease causing genes, which are 5,000 to 8,000 in number. So, it's a smaller panel than whole exome sequencing. Now, when for a condition like, say, a muscular dystrophy, wherein, I'm already suspecting a limb girdle muscular dystrophy, say I'm already suspecting by a clinical assessment, I'm suspecting a sarcoglycanopathy, for which all the genes I know they are very well characterized in literature. They will be there in a clinical exome. I can go ahead and do a clinical exome. However, for a condition like developmental delay with no other, where I don't have a clue that, what gene could be involved, in that, I would like to do a whole exome sequencing, or a non-specific intellectual disability, where a geneticist, as a geneticist also, I can't sort of pinpoint that, this is the group of disorders that I want to look at. Then I would want to go for a whole exome sequencing, wherein all the genes are analyzed, because more and more, intellectual disability genes are getting diagnosed also. I mean, more and more genes are getting characterized each day, which may not be there in clinical exome. So for a phenotype, for a definite phenotype, where I want to look at, say, mucopolysaccharidosis, I'm very sure that this is mucopolysaccharidosis, then I can easily go for a clinical exome or for a panel which includes those genes. However, for something which I'm less sure of, I should go for a whole exome. Now, for regarding the labs, it is difficult. Lot of small labs coming up. There are platforms on which gene sequencing should not be done for a diagnostic purpose. So they are doing it on those platforms. Those are smaller platforms, less sophisticated. The data generated is of much lesser depth. So I would say that, that it is, well established labs, and, we should look at how the report is getting generated, maybe ask for a sample report. Maybe, initially when we are sending the sample, I would want to send to 2 labs. To the newer one, I would say that, you validate some sample for me, do my patient sample for free, and then send it to a good established lab as well. Then correlate the results of the two. And, if we really feel that this lab has credible results, then only start to send the sample there.
Right. One more question. The last one is from Dr. Deepa. How would you decide between array or whole exome sequences when they can afford only one?
I'm so happy that someone asked,
Somebody asked that question.
because now sir knows, because now whole exome sequencing, because I told you that sequencing is used for sequencing the genes. That means finding out the sequence of the genes which diagnoses traditionally the single gene disorders. However, now whole exome sequencing is now being used also for diagnosing chromosomal disorders. Somehow the data is sort of analyzed to report any regions of chromosomes that could be deleted or duplicated. So you could just do a whole exome sequencing and ask the lab to run a copy number analysis, which sort of diagnoses the chromosomal deletion duplications as well. So that's how, we would do.
So there is a catch here, Dr. Divya, what it is, because that's what I've experienced the last 5 years. People, they will just, unless you are very well, I mean, now I'm sure people are knowledgeable here in the group and they can ask that question, but not normally they will say initially, no, sir, we don't do this. You have to know the CNV, you have to ask for microarray and the panel plus exome sequencing. A combination will cost this much and that much. This is all marketing gimmicks. I mean, we know that if you twist the finger, they will be able to do it. They can do it. They have the platform, they have the facility. But because this will be less remuneration for them, so they don't normally say that unless you are knowledgeable enough to ask them that specific request.
Yes, sir. Absolutely.
Right. I think that's it about. Any other questions? No, really, no other questions. Information is there, which I'm sure we did. So that's all. No more questions. Over to Dr. Bimal.
Okay,
Sandhya,
thank
madam,
you, everyone. Lovely talk, Divya. Excellent, and really gave us a good overview of genetic disorders, which cleared all the cobwebs from my mind just now. Thank you, sir. Thank you very much, sir, for moderating the session. And I think we all have really learned a lot in this session. Thank you so much.
it was a
And you made
difficult
such a
subject.
complicated
Yeah, madam.
subject, so
Yeah.
simple and so easy. That's the biggest, message we got today. Very
Div-
easy.
Divya has
Thank you.
presented with beautiful multicolored pictorial presentation slides.
Excellent.
That was interesting.
Thank you, everyone.
everyone.
Thank you, everyone, for attending also. And good night.
Good night, everyone.
Thank you,
Good
sir.
night.